Hi, everybody. This is Ed Pavlik in Lexington, Kentucky, with another edition of GYN ONC Garage, where we look under the hood at certain papers. I'm joined with my partner here across the pond in a country that just got a new prime minister. Frank, how are you doing?
Yes, very well, thank you. We'll see how long this prime minister lasts. We're getting quite good at swapping politicians in this country. Nice to speak to you again.
Well, we take on, once again, a paper where we can look at things that are positive and things that are maybe still open to question. The paper today that we want to look at was in JAMA Oncology. It's a recent paper. It's done by 6 investigators at Memorial Sloan Kettering and Dartmouth. And basically, it takes up where a paper in 2019 left off. Which used only 5 women that had pancreatic cancer. And this one uses 446. Basically, the title of this paper is Association Between Polycystic Ovarian Syndrome and the Risk of Pancreatic Cancer. It's a research letter, probably because it's a follow-up study to what was done before. Frank, what do you think of this paper?
I have to admit that I was aware, but didn't really appreciate any real link between polycystic ovary syndrome and pancreatic cancer. As a gynecologic oncologist, you don't see any cases of PCO, but as a general gynecologist, of course, one would. And we did see quite a number of cases of PCO at our tumor board, which were obviously found to be a benign condition. So anyway, there apparently is a link between pancreatic cancer and PCO, but looking at various websites, which includes the Cancer Research Campaign in the UK and the National Health Service, and Johns Hopkins and the Mayo Clinic and a pancreatic cancer helpline, there is no mention whatsoever of the risk of polycystic ovary syndrome leading to pancreatic cancer. So it's certainly well down the list of risk factors. And I was just looking at the risk factors for pancreatic cancer: smoking, 22% of cases, overweight, obviously diabetes and growth hormone problems, insulin problems, 12%, family history, 10%. So if this paper is true, which is about 2%, it's way down the list of risk factors, I think. I assume that it's difficult to know how long it took to recruit these patients, but I assume that the Rotterdam criteria were used to make the diagnosis of PCO, which of course is polycystic ovaries, hyperandrogenism, infertility or oligomenorrhea, and hormonal problems as well. So I assume that the diagnosis is correct from that point of view. The way they've chosen the subjects, however, the question, and they actually stated, have you had polycystic ovaries? And I think that's a very strange definition for a paper that's trying to talk about polycystic ovary syndrome. 40% of women will have had, if they've had an ultrasound, will have had a diagnosis of polycystic ovaries, but it doesn't necessarily mean they have polycystic ovary syndrome. So I think the selection might be a little bit problematic there. And also, I think, what sort of treatment did they have? Obviously, there are degrees of polycystic ovary syndrome. Some people just can be treated with weight loss, some people with oral contraception, clomiphene, all sorts of things. So I think the severity of the PCO syndrome hasn't really been addressed in this paper. I think the other problem is that the numbers are, although the numbers are fine, there's only 2% of these cases. I think, in the control group, I've got it here, polycystic ovary syndrome, 11% of the control group had PCO in the pancreas, and 9% in the control group, which is actually, the numbers are pretty similar. So I'm not so sure about how important from a point of view of women's health, having PCO and with a possibility of pancreatic cancer is important. The other problem, of course, is that PCO or PCOS is a disease or problem of women of reproductive age. I think the peak incidence is probably well under the age of 40. And yet, as they say in this paper, the age of the diagnosis of the cases was mean age of 63.8. So the lead time between PCOS and development of pancreatic cancer, or at least in this clinic, is some 20 years. And I think if they're going to screen patients over 20 years to find only the 2% or so of patients with PCO that will go on to develop pancreatic cancer, it's a very, very expensive and probably not very productive screening method.
Frank, I think you're absolutely right. I think this is a good way to look at perhaps a first step. The only difference that I noted that might be useful in going forward between the control group and the group with pancreatic cancer was that those with diabetes were about 5 times more likely to be in the pancreatic group. So diabetes might be thrown in there as a requirement for people with polycystic ovarian syndrome. So that's one thing I would say. The case control study was done at Sloan Kettering, basically, and it may reflect the population that occurs in New York City. To put your numbers in perspective, the incidence of pancreatic cancer is 61 per 100,000, roughly, give or take. And the incidence of polycystic ovarian is 12,000 per 100,000 women. That translates into your numbers that you're looking for 61 people out of 12,000 candidate people. And that's about screening at a level for a yield of 0.5%, even lower than you said. There has to be a way of making that just a slightly bit better. It might well be that the first screen is followed because of the length of time you described between onset of pancreatic cancer and perhaps PCO to screen in 10-year intervals. That might be something that would make this work. But right now, I think we don't want people who have PCO to be running looking for screening.
Absolutely.
I'd say from a theoretical standpoint or consideration standpoint, one would have to wonder, in my mind, scientifically, what's the overlap between mutational genes in the PCO syndrome and pancreatic cancer. And there have been a number of mutated genes found for PCO, but there's very little overlap that I could find with the mutated genes for ovarian cancer, for pancreatic cancer, excuse me. So, I mean, I think that's the problem that exists right now. That's my comment on the whole thing. Frank, anything else to add?
No, I think that it looks like an illness trying to find a screening method. And you and I know that a lot of diseases have great potential for screening, but in the real world, how on earth you would encourage women, or discourage women from going into some sort of screening study just because they've had a diagnosis of PCO. And I suspect most clinicians, most physicians don't even know that there's this slight link between the two problems. So I think it's an interesting paper, and I think it clearly shows that it's probably more to do with the genetics of both of the diseases, isn't it? Or in some way to do with insulin resistance or pancreatic function. And the other thing, and you may be more aware of this than I am, I don't know how good imaging is in diagnosing benign pancreatic cysts from potentially malignant pancreatic cysts. They go into it a little bit in one paper that I've read, but what on earth is going to be the false positive rate in this? Unless, of course, they're carried out in centres, presumably like the MSK Pancreatic Centre, where they have at least a reasonable number of patients going through. But I can't see it taking off in the next few years anyway.
I think that's a difficulty. The ultrasound by endoscopy, I think, probably will not be very definitive, though it's used. And probably then the MRI, which is the other tool that's used, probably raises the cost threshold a lot. Try and utilize that. So the question really boils down to how they distinguish something at the screening step. So.
Yeah, that's the problem, I think. Yeah.
Okay, very good.
Yeah.
Good to see you again.
Yeah.
And we'll look forward to doing this next month again.
Yes, indeed.